everyone, and welcome to today's webinar where we will be discussing the medical devices used in PALS. Understanding that resuscitation tools are available is an essential component of PALS. These adjuncts are broken down into two subcategories: medical devices and pharmacological tools. A medical device is an instrument used to diagnose, treat, or facilitate care. Pharmacological tools are the medications used to treat the common challenges experienced during a pediatric emergency. It is important that thorough understanding is achieved to optimally care for a child or an infant that needs assistance. In this webinar, we will be discussing specifically medical devices. The relative softness of bones in young children makes intraosseous access a quick, useful means to administer fluids and medications in emergency situations when intravenous access cannot be performed quickly or efficiently. Fortunately, any medication that can be given through a vein can be administered into the bone marrow without dose adjustment. Contraindications include bone fracture, history of bone malformation, and insertion site infection. Please note, IO access should not be attempted without training. So for IO access, place the patient in the supine position. Support the knee with a towel roll. Use universal precautions. Prepare the skin with betadine or use specific intraosseous needle or a large bone. Find tibial tuberosity below knee joint. Stabilize the leg with slight external rotation. Insert the needle firmly but gently. Resistance will suddenly drop when in the marrow. Do not aspirate. Rapidly infuse 5 milliliters of fluid. Keep IV bag under pressure. Stabilize and secure the needle. When performed appropriately, bag mask ventilation is an important intervention in PALS. Proper use requires proper fit. The child or the infant's mouth and nose should be covered tightly, but not the eyes. When possible, use a clear mask since it will allow you to see the color of their lips and the presence of condensation in the mask, indicating exhalation. The two most common types of bag mask are self-inflating and flow-inflating. While self-inflating bag mask should be the first choice in resuscitations, it should not be used in children or infants who are breathing spontaneously. Flowing inflating bag masks, on the other hand, require more training and experience to operate properly, as the provider must simultaneously manage gas flow, suitable mask seal, individual's neck position, and proper tidal volume. The minimum size bag should be 450 milliliters for infants and young or small children. Older children may require a 1,000 milliliter volume bag. Proper ventilation is of utmost importance as insufficient ventilation leads to respiratory acidosis. So the proper position: in the absence of neck injury, tilt the forehead back and lift the chin. Create a tight seal. Use the EC clamp, which is the letters E and C formed by the fingers and thumb over the mask. And then ventilate. Squeeze the bag over 1 second until the chest rises, and do not overventilate. Endotracheal intubation is used when the airway cannot be maintained, when bag mask ventilation is inadequate or ineffective, or when a definite airway is necessary. Inserting an ET tube requires specialized training, and a complete description is beyond the scope of this webinar series. For further information on ET intubation, visit our PALS certification and training course on savealife.com. The oropharyngeal airway, or the OPA, is a J-shaped device that fits over the tongue to hold the soft hypopharyngeal structures in the tongue away from the posterior wall of the pharynx. OPA is used in persons who are at risk for developing airway obstruction from the tongue or from a relaxed upper airway muscle. If efforts to open the airway fail to provide and maintain a clear, unobstructed airway, then use the OPA in an unconscious person. An OPA should not be used in a conscious or semi-conscious person because it can stimulate gagging and vomiting. The key assessment is to check whether the person has an intact cough and gag reflex. If so, do not use the OPA. The nasopharyngeal airway, or NPA, is a soft rubber or plastic uncuffed tube that provides a conduit for airflow between the nares and the pharynx. It is used as an alternative to the OPA in persons who need a basic airway management adjunct. Unlike the oral airway, NPAs may be used in conscious or semi-conscious persons, which are persons with intact cough or gag reflex. The NPA is indicated when insertion of an OPA is technically difficult or dangerous. Use caution or avoid placing NPAs in a person with obvious facial fractures. Suctioning is an essential component of maintaining a patent airway. Providers should suction the airway immediately if there are copious secretions, blood, or vomit. Attempts at suctioning should not exceed 10 seconds. To avoid hypoxemia, follow suctioning attempts with a short period of 100% oxygen administration. Monitor the person's heart rate, pulse, oxygen saturation, and clinical appearance during suctioning. If a change in monitoring parameters is seen, interrupt suctioning and administer oxygen until the heart rate returns to normal and until clinical condition improves. Assist ventilation as warranted. So to insert an OPA, clear the mouth of blood and secretions with suction if possible. Select an airway device that is the correct size for the person. So too large of an airway can damage the throat, whereas too small of an airway can press the tongue into the airway. Place the device at the side of the person's face. You want to choose the device that extends from the corner of the mouth to the earlobe. Insert the device into the mouth so that the point is towards the roof of the mouth or parallel to the teeth. Do not press the tongue into the back of the throat. Once the device is almost fully inserted, turn it until the tongue is cut by the interior curve of the device. To insert an NPA, select an airway device that is the correct size for the person. Place the device at the side of the person's face and choose the device that extends from the tip of the nose to the earlobe. Use the largest diameter that will fit. You should lubricate the device with a water-soluble lubricant or anesthetic jelly. Insert the device slowly, moving straight into the face, not towards the brain. It should feel snug, but do not force the device into the nostril. If it feels stuck, remove it and try the other nostril. Then some tips on suctioning include when suctioning the oropharynx, do not insert the catheter too deeply. Extend the catheter to the maximum safe depth and suction as you withdraw. When suctioning an ET tube, remember the tube is within the trachea and you may be suctioning near the bronchi or lung. Therefore, sterile technique should be used. Each suction attempt should be for no longer than 10 seconds. Remember the person is not getting oxygen during suctioning. Also monitor vital signs during suctioning and stop suctioning immediately if the person experiences hypoxemia or oxygen sats that are less than 94%. Has a new arrhythmia, or becomes cyanotic. If you look around the public places you visit, you're likely to find an automated external defibrillator. An AED is both sophisticated and easy to use, providing life-saving power and a user-friendly device. This makes the device useful for people who have no experience operating an AED and allows successful use in stressful scenarios. However, proper use of an AED is very important. The purpose of defibrillation is to reset the electrical systems of the heart, allowing a normal rhythm a chance to return. Using an AED is indicated when there is no response after tapping and shouting, no breathing or ineffective breathing, and no pulse is detected. So to use an AED, first retrieve the AED, open the case, and turn the device on. Expose the infant or child's chest. If the chest is wet, quickly dry the chest. If there are any medication patches on, remove those. Open the pediatric AED pads. If pediatric pads are not available, use adult pads. Just ensure that the pads do not touch each other. Peel off the backing and check for a pacemaker or defibrillator. If present, do not apply the patches over the device. Apply the pads, one to the upper right chest above the breast and the other to the lower left chest below the armpit. Ensure the wires are attached to an AED box. Move away from the person, stop CPR, and instruct others not to touch the person while the AED analyzes the rhythm. If the AED reads check electrodes, then ensure the pads are making good contact. If the message indicates that a shock is advised, then deliver the shock, and then resume CPR for 2 minutes and repeat this cycle. Don't forget we offer online PALS certification on our site. We encourage you to become certified as soon as possible, whether that be on your own time with an online course or in an in-classroom setting. You can find a link to our course in the description. So thank you so much for tuning into today's webinar. We will catch you the next time.